Staff allowed in hospitals and what people need to do in their plan to access it. So we're still getting the, I'll tell you what you need to do in your plan, but we're still working on getting the codes in place. I just want you to know we don't have the coding in place yet to just easily bill, but I will tell you, if you have a need, call me and we will take care of figuring out a way to get it done for your particular family. But the issue before was, a hospital is an acute care setting, and what that means is that they cover 100% of your care needs. That was the theory. And what we learned over time was, well, I think what we learned a long time ago, was that if a person with disabilities is in the hospital is not equipped to meet the service needs of somebody with disabilities. And they were really, a lot of their needs were being neglected. Or what was happening was family members or providers were going in and providing that service support, or not being allowed to go in to provide the service support, to the detriment of the person with disabilities. And so a lot of advocacy went into getting legislation passed that would allow somebody who has a disability and receiving Medicaid for their service provider to be able to go into the hospital, provide the service needs necessary that weren't being provided by the hospital, so that you could bill somebody in acute care service needs that weren't otherwise being provided by the hospital. And it wouldn't be looked upon as duly providing services. In the past, of acute care, again, it used to be considered 100%. Therefore, if your service provider went in, it looked like you were double dipping, as they call it, billing into the same pot, Medicaid. So since it was 100% care, DD billed, it looked like you were billing for the same service and was overlapping billing. Now it's recognized that different needs need to be provided for, so you can provide acute hospitalization and the service needs that the hospital doesn't provide while the person's in the hospital. The coding isn't up and running, but we are ensuring that the need is going to be met while the parties that be the Medicaid team and the Gainwell team, who's the Medicaid biller, get this up and running so it moves along more smoothly. But we have worked with families just to do it, to make sure that those service needs are being met now. So Bill stated that he had a son in the hospital who came to the hospital from a group home, and the group home staff was able to assist, which he said was invaluable to his son and their family. There were complications because the hospital stated for liability reasons that they needed to be in the room too, which created some privacy issues for his son and the family. So we have some more work to do. We're going to follow up on that and see that as we finalize implementation of this, if we can resolve the issue with the hospital, that they can really meet the patient's needs for not only having support in the room, but privacy as well. Is that good, Bill? John? As we move forward on ISPs, in order to access codes, Medicaid codes, it actually has to be part of your ISP to be able to state that you need to be able to, in order to access the plan, you just can't say, I got in a car accident, so I want people to be able to come and support me. It needs to be part of your ISP prior to your hospitalization. Or an amended ISP would need to be done in order to do it. So it actually has to be part of your service plan.
So that would just be a statement or something in the ISP? Would it need to have something in the purchase order?
No, I don't think it has to be. I'm going to say no on that. If that has to be corrected, I'll get that out. But I think a purchase order can be done easily. It's just that it has to be part of the service plan. So when the need arises, a purchase order can be done.
So Kevin, could it be in the at-risk section?
Yeah.
At the end, like part of the narrative?
Yes.
And there's another question in there that, is there any other information you want to provide? Could it be?
But not everybody would need it. So I would suggest that if you're going to be in the hospital and all you'd want is your family there and not your DSP, you don't have to put it in. But if you're a person who absolutely needs or has a high likelihood of needing, you should get it in your service plan.
Is there any language that should definitely be in there, certain words, or that should absolutely be part of whatever's in the plan?
I don't think so. What do you need? That's really the service plan, like what do you need?
It's very difficult. You have to be specific in your plan. You be very specific.
I'd have the trainers on conflict free actually deal with that, but it's if you're anticipating that you need someone with you when you're in the hospital, just identify it in the service plan. We're working with the conflict free case management group, whether it's an independent facilitator or conflict free case management, on those types of questions when they're working with people. So they'll talk to you about it. I don't want people to miss out on it, and if we had to amend your plan to do it, we will. But it's good to have it in there if you know you're going to need it. If you're a person who knows you need 24-hour care, knows that a hospital could not provide that kind of support, and you need your person there, then we'll make sure and work with you to make sure you get it in your plan.